Hello, friends! Today we're going to delve into a topic that gives even Americans themselves a headache: the U.S. health insurance system. When it comes to the United States, many people will think of its advanced medical technology, but few people know that this country's health insurance system is so complicated that it is crippling. High costs, cumbersome rules, and hidden traps have put countless people in a difficult position to see a doctor and pay their bills. Today, we're going to take you step by step through the most straightforward way to dismantle this profit-bound system and decipher what key facts that affect millions of people's rights and interests are hidden behind all the eye-opening jargon. First of all, we need to be clear that the core of the U.S. healthcare system is privately led, which is fundamentally different from the universal healthcare system we know. This private landscape did not develop in a single day, and its history can be traced back to the World War II Landry Act. The act allowed corporations to deduct healthcare expenses as a cost of doing business, directly contributing to the rise of employer-sponsored healthcare, and gradually putting private insurers at the center of the healthcare market. To this day, about 60% of the U.S. population relies on private healthcare, with government-led healthcare programs serving only as a supplement to cover specific populations such as the elderly and low-income groups. What confuses the population most is the compartmentalized nature of the system. Basic healthcare is separate from dental and vision insurance. This is not based on medical definitions, but stems from the division of labor in the industry and the segmentation of the insurance market. This separation is further exacerbated by the long history of independent operation of the American Dental Association and medical societies. According to the most recent data, about 40% of American adults do not have dental insurance, while vision insurance coverage is only about 55%. Many low-income families forego necessary visits because they can't afford the extra premiums, which has resulted in the U.S. having one of the highest rates of dental disease in the developed world. Even more unacceptable is the high cost of healthcare in the U.S. A report by the U.S. Department of Health and Human Services 2025 shows that the annual per capita healthcare expenditures in the U.S. are as high as $14,500, which is 2.3 times higher than the average of the Organization for Economic Cooperation and Development (OECD), and is firmly ranked as the first in the world. Specific to the various aspects of healthcare, a day of hospitalization costs an average of $2,800, and a general outpatient visit costs about $350. And the average cost of a common operation like heart bypass is as high as $150,000 United States dollars. Cancer treatment costs more than $200,000 United States dollars a year. Behind the high cost of healthcare is a tight chain of interests consisting of health insurance companies, pharmaceutical companies, and medical institutions. Among them, lobbying is a key factor in driving up costs and impeding reform. Data show that the American Health Insurance Association and major insurance companies spend a total of more than $50 million a year on lobbying. Among them, Blue Cross Blue Shield, which covers nearly one-third of Americans, spent $4,840,400 on lobbying in 2025 in Kansas alone. Commitment remains unchanged at between $25 million and $28 million. These funds are primarily used to influence healthcare policymaking, resist the rollout of public healthcare options, and oppose reforms such as drug price controls that could reduce industry profits. This ultimately leads to a very low level of transparency in the U.S. healthcare system, making it very difficult for people to get clear information about costs and a fair deal on coverage. To understand the entire system, the next big concern must be, how exactly do you pay for U.S. healthcare? The rules here are so complex that it makes people dizzy, and they are all nested in each other's terms. Let's break it down step by step. First, there's the premium. Premiums are the basis for maintaining eligibility for health insurance, just like when we subscribe to a video platform and pay a fixed monthly fee. But unlike a subscription, once you stop paying the premium, your health insurance eligibility ends immediately and there is no retroactive coverage. Premiums vary greatly between different types of health insurance options, with the average monthly premium for an HMO option purchased by an individual being $480, an APPO option being as high as $720. according to the Kaiser Family Foundation 2025 survey. In the case of employer-sponsored health care, employees are responsible for an average of $140 per month for a single plan and $630 for a family plan, with the employer paying the remainder. Premium pricing is not random. Insurers base their pricing on factors such as age, geography, health status, and coverage, and state insurance regulators have more limited constraints. Next up is the deductible. Simply put, a deductible is the amount of money an individual is responsible for paying on their own before the insurance company begins to pay. Deductibles and premiums have an inverse relationship. Low premiums correspond to high deductibles, such as up to $8,300 for a catastrophic health plan, while high premiums correspond to low deductibles, with some higher-end PPO plans having no deductibles at all. Under IRS 2025 standards, the minimum deductibles for high-deductible health plans are $1,650 for a single person and $3,300 for a family, an increase of $50 and $100, respectively, compared to 2024. It's important to note that preventive medical services, such as routine checkups, generally do not count toward the deductible. Even if the deductible is not met, services are available for a small fee. However, even if you meet your deductible, it doesn't mean that your insurance company will pay for it in full. There are two thresholds to cross: co-payments and co-insurance. Co-payments are fixed out-of-pocket expenses, such as $30 for a general office visit, $50 for a box of prescription drugs, and $150 for an emergency room visit. These costs are based on the type of service and usually do not count toward the deductible, but some insurance programs may include them in the calculation of the annual deductible. Co-insurance, on the other hand, involves sharing the cost on a sliding scale, commonly 20 or 30%, and in a few programs, the individual may even be responsible for 100% of the cost, meaning there is little to no insurance coverage. For example, for a $1,000 specialty visit, an individual would be responsible for $200 if the co-insurance percentage is 20%. The annual out-of-pocket maximum refers to the maximum medical expenses an individual is responsible for in a single year. The federal rates for 2025 are $8,300 for a single person and $16,600 for a family, an increase of $250 and $500, respectively, compared to 2024. Once this cap is reached, subsequent eligible medical expenses will be covered in full by the insurance company. However, there's a major catch here. Costs from non-network providers typically don't count toward the out-of-pocket maximum. For example, if you are taken to a non-network hospital for an emergency, even if it costs $10,000, you may have to cover the full amount on your own with no deductible credit. In addition, the premium itself does not count toward the out-of-pocket maximum. Even if you pay a high monthly premium, you are still responsible for your own expenses until you reach the out-of-pocket maximum. Having understood the payment rules, let's take a look at the four mainstream health insurance options in the US: HMO, PPO, EPO, and PAWS. Their core differences lie in premiums, network coverage, and referral requirements to meet different needs and budgets. Of these, the HMO option is the most common in the individual health insurance market, with a 45% market share in 2025. The advantage of the HMO option is its low premiums, which average $480 per month for individuals and $1,150 per month for families, 15% to 20% lower than other options. However, HMOs also have many limitations. You must be in the network designated by the insurer or you won't be reimbursed a penny. And there are usually a limited number of providers in the network, a problem that is even more pronounced in rural areas, where there may be only a few core hospitals. In addition, visits to specialists must be preceded by a referral from a family doctor. If there is no proof of referral, one is required to bear the full cost of the specialty on one's own. This design is intended to reduce unnecessary expenditures by screening conditions through the family doctor, but it also results in less flexibility in accessing care and possible delays in treatment during emergencies. HMO coverage is primarily for primary care, prescription drugs, and preventive care. If dental and vision coverage is needed, Additional supplemental insurance is required. In contrast, PPO options are more common in employer-sponsored health insurance, with a 58% share in 2025. PPO premiums are relatively high, averaging $160 per month for an employee and $680 per month for a family in employer-sponsored health insurance, or $750 if an individual purchases on his or her own. However, PPOs are much more flexible, with a network of services that is 2 to 3 times larger than HMOs, and almost all mainstream hospitals in major cities are in their network. PPOs also allow patients to visit providers who are not in their network, which will just cost more. Most importantly, PPO plans allow patients to schedule appointments directly with specialists without the need for referrals, which saves a great deal of time. Additionally, some high-end PPO plans include dental and vision services as supplemental coverage, further enhancing their appeal. EPO plans, which account for approximately 12% of the market, have core features of limited network and no referral required, similar to HMOs but more flexible in terms of referral requirements. EPOs have about the same number of in-network providers as HMOs and primarily cover the core institutions in the region. Non-network visits are not reimbursed except in emergencies. EPO premiums are close to those of HMOs, with an average monthly premium for individuals of $510. The key difference between EPOs and HMOs is that EPOs allow for direct access to specialists without the need for referrals through a family physician, making them more suitable for younger people who are in good health but who need occasional specialty visits. POS programs are a hybrid of HMOs and PPOs with a market share of about 5%, and their core rules are family doctor-driven and cross-network access after referral. POS requires a family doctor to be named, routine visits to be routed through the family doctor, and cross-network visits to be partially reimbursed with a referral from the family doctor. Typically, co-insurance is 40% to 50%, with no reimbursement without a referral. Their premiums fall between HMOs and PPOs, averaging $580 per month for individuals and $1,350 per month for families, and are suitable for those who want to control costs but may have a need for cross-network care. These 4 options are essentially trade-offs between cost and flexibility. People should choose based on their health status, medical habits, and financial strength. Insurance companies, in turn, use this segmentation to accurately meet the needs of different markets. In addition to the health insurance program itself, there are several types of medical savings accounts with tax benefits in the United States, namely health savings accounts HSAs, medical expense savings accounts MSAs, flexible spending accounts FSAs, and health benefit accounts HRAs. However, each of these accounts has strict conditions that apply and not everyone can benefit from them. First up is the HSA, or Health Savings Account. Only people with a high-deductible health plan can open this account. Its core advantage is a triple tax benefit. Funds deposited into the account are deductible on a pre-tax basis. Investment earnings are exempt from capital gains tax, and withdrawals are not subject to personal income tax when used for qualified medical expenses. In 2025, HSA contributions are capped at $4,300 for a single person and $8,550 for a family. For those 55 and older, an additional $1,000 can be deposited. It is important to note that only 2% of healthcare Duke Marketplace enrollees choose an HS-eligible plan in 2025, a significant drop from 7% in 2020, primarily due to the incompatibility of the standards of the existing high-deductible plans with Obamacare's benefit design requirements. The HSA account is owned by the individual, and the funds can be rolled over from year to year without affecting the plan in the long term, even if a person changes jobs or health care. The HSA account is owned by the individual, and the funds can be rolled over from year to year, so changing jobs or health insurance programs will not affect the HSA account, making it a good tool for long-term medical savings. Eligible medical expenses include doctor's office visits, prescription drugs, and hospitalization costs, but over-the-counter medications are not included unless prescribed by a doctor. Non-essential services such as cosmetic surgery are also not covered. MSAs, or medical savings accounts, are similar to HSAs but are more limited in scope. MSAs are only available to self-employed individuals with high deductible plans, or who are enrolled in Medicare and meet certain qualifications. The tax benefits of an MSA are essentially the same as those of an HSA, but with lower contribution limits. In 2025, the contribution limit will be $4,150 for a single person and $8,300 for a family. There are no additional contribution limits for those over age 55. In contrast to HSAs, MSA funding can include subsidies from insurance companies. Some insurance companies will provide startup funds for participants, while HSAs rely heavily on personal savings and employers can provide additional subsidies. Because of their narrower scope of application, MSAs have minimal coverage and are used by only about 1 million Americans, most of whom are self-employed. FSAs, or flexible spending accounts, are available only through employers and cannot be opened individually by individuals, independent of the type of healthcare program. The annual contribution limit for FSAs is $3,300 in 2025, an increase of $100 from 2024. Contributions are tax-deductible and can be used to pay for qualified medical expenses, childcare expenses, etc. FSAs have strict use-it-or-lose-it rules, whereby current year funds must be used in the current year or they will revert to the employer. However, some employers offer two exceptions. They either allow up to $660 to be carried over to the following year, or they offer a grace period of up to 2.5 months, until March 15th of the following year, to use the previous year's funds. In the event of separation from service, unused funds cannot be taken away or returned. FSA coverage is high due to low setup costs and the ability to be paired with a variety of healthcare options. In 2025, approximately 62 million working Americans had access to FSAs through their employers. HRAs, or health reimbursement arrangements, are also offered by employers and are fully funded by the employer with no individual contributions. The funds contributed by the employer are deductible on a pre-tax basis, and the reimbursements received by the individual are exempt from personal income tax. The scope of reimbursement under an HRA is determined by the employer and typically includes core medical expenses, with some employers also including dental and vision exams. HRAs are categorized as traditional, integrated, or individual coverage based on the rules for using the funds. Traditional requires employees to pay out-of-pocket expenses before being reimbursed with a bill at an amount set by the employer. Integrated is required to be paired with a high-deductible plan for reimbursement of deductibles, co-payments, etc. And individual coverage is subsidized by the employer and can be used by the employee to purchase health insurance or to pay for healthcare expenses. HRA funds cannot be carried forward, and unused reimbursements for the current year will automatically be zeroed out and not be eligible for reimbursement after separation from employment. In 2025, about 1.5 million HRA funds will be available to employees enjoy. In 2025, approximately 26 million U.S. workers will have access to HRA benefits. Small and medium-sized businesses are the primary users of HRAs because they have a lower threshold to set up than FSAs and less funding pressure. The core value of all four accounts is to reduce healthcare spending through tax benefits, but the applicability scenarios are restricted. People without high deductible options cannot use HSAs and MSAs, and people without employer health benefits cannot use FSAs and HRAs. This results in a large number of freelancers and low-income people not being able to take advantage of these benefits, further exacerbating healthcare coverage inequality. With an understanding of private health insurance in mind, let's look at the two core healthcare programs dominated by the U.S. government: federal Medicare and Medicaid. Although both programs are part of the public healthcare system, there are significant differences in their eligibility, funding sources, coverage, and management mechanisms, which together constitute the safety net of healthcare in the United States. However, there are significant differences in the populations they cover and the level of coverage. The first is the federal health insurance, i.e. Medicare, which is a purely federal government program. Established in 1965 through the Social Security Act, The core of the program is to provide coverage for seniors over the age of 65, while also covering some people with disabilities and patients with end-stage renal disease. Eligibility is standardized by the federal government and is not related to income. U.S. citizens or legal permanent residents who are 65 years of age or older and have lived in the United States for 5 years are eligible to enroll. In addition, people with disabilities who are under age 65 but have been receiving Social Security disability benefits for 24 months and people with end-stage renal disease at any age are also eligible for Medicare. According to CMS, the number of Medicare enrollees will reach 68.9 million in 2025, of which 85% will be 65 or older, 13% will be disabled, and 2% will have end-stage renal disease. Medicare is divided into 4 parts, each covering different medical services. Part A is hospitalization insurance, which mainly covers inpatient treatment, hospice care, and skilled nursing facility services, and is financed by the health insurance tax paid by employers and employees to 0.9% of payroll, with employers and employees each contributing 1.45%, and self-employed persons contributing the full 2.9%, as long as they meet a tax payment history of at least 10 years. Enrollees do not have to pay the monthly premium for Part A. In 2025, the Part A hospitalization deductible is $1,632. Participants pay no additional cost for the first 60 days of each hospitalization, and after 60 days there is a coinsurance of $371 per day. Part B is Medicare, which covers items such as outpatient services, doctor's office fees, preventive care, and medical equipment. It is funded by federal dollars 75% and monthly premiums paid by enrollees 25%. The standard monthly premium for Part B is $185 in 2025. For higher income individuals, the premium will be higher, up to $628.90. The annual deductible for Part B is $257, beyond which enrollees are responsible for a 20% coinsurance. Part C is a Medicare Advantage plan, underwritten by a private insurer that replaces the traditional Part A and Part B. Enrollees must qualify for both Part A and Part B and pay the monthly premium for Part B. The premium for Part B is $257 per year with a 20% coinsurance. Some Advantage plans charge a small additional premium, averaging $17 per month. Advantage plans have broader coverage, often including prescription drugs, dental and vision, and other services not covered by Part A and Part B. In 2025, about 35.2 million Medicare enrollees chose an Advantage plan, or 51.2% of the total number of enrollees. Additionally, in more than 2/3 of the nation's counties, United Health or Humana hold the largest market share, together accounting for nearly 60% of total enrollment. Part D is prescription drug coverage, also underwritten by private insurers. Enrollees can choose their own coverage options. In 2025, monthly premiums will average $58 with an annual deductible of $5,050. After the annual deductible exceeds $5,050, the catastrophic coverage phase begins. During this phase, enrollees pay a small copay, $5 for generic drugs and $15 for brand-name drugs. Medicare is administered by CMS and is consistent across the country with no regional variations. Another government program is Medicaid, which is jointly funded by the federal and state governments and administered under state leadership. At its core, it provides coverage for low-income individuals and families, with eligibility for coverage based primarily on adjusted gross income. The federal poverty level standards for 2025 have been adjusted upward by 7% from 2024, and the federal government has set a minimum eligibility standard of $22,590 for a single person with an annual income of less than 138% of the federal poverty level. The federal government has set a minimum eligibility standard of $22,590 for a single person with an annual income of $22,590 for a single person. However, states can increase participation standards based on their fiscal situation, so eligibility varies significantly from state to state. For example, California has raised its single-person enrollment income limit to 138% of the federal poverty level, while Texas maintains only the federal minimum standard and has yet to include low-income adults without children in its coverage. The Medicaid coverage population consists primarily of children in low-income families, parents, pregnant women, seniors, and people with disabilities. Of the 2025 enrollment, 7.2 million low-income seniors are concurrently enrolled in Medicare, in addition to 4.8 million people with disabilities. The total number of dual enrollees reaches 12 million, or more than 15% of all Medicaid enrollees. In terms of funding, the federal and state governments share proportionately. For low-income states, the federal share can be as much as 78%. For high-income states, the federal share is 50%. In terms of coverage, the federal government specifies the services that must be covered, including outpatient, inpatient, prescription drugs, preventive care, and pediatric dentistry. In addition, states can add their own optional services, such as adult dentistry, vision care, and long-term care, as they see fit. Because of state-led administration, there are significant regional differences in Medicaid coverage levels and service networks. Financially strong states, such as California and New York, have a full range of optional services and a large number of providers in their networks, while financially strapped states, such as Mississippi and Alabama, have fewer optional services and may limit the number and cost of visits. To summarize, there are three core differences between Medicare and Medicaid. 1. The basis for eligibility is different. Medicare is based on age and disability, not income. Medicaid is based on low income. 2. Funding and administration are different. Medicare is a purely federal program with uniform policies across the country. Medicaid is shared by both the federal and state governments and led by the state government, with large regional differences. The scope of coverage is different. Medicare focuses on the elderly and specific groups of people with disabilities and emphasizes basic services, while Medicaid covers the entire population of low-income people, and the coverage in some states is more comprehensive. These two programs are often confused, mainly because of their similar names and the fact that they are both government health care programs. However, they are in fact complementary coverages for different groups, designed to fill gaps in private health care. However, there are still many low-income people who are not adequately covered due to the limited level of coverage and wide regional variations. Finally, let's talk about the practical issue that everyone is most concerned about: how to grasp the critical window of time and avoid the hidden traps when purchasing health insurance in the US. This is directly related to whether you can successfully obtain insurance coverage and the amount of money you need to spend. First, we need to understand the two core windows of time: the open enrollment period and the special enrollment period triggered by qualifying life events. The open enrollment period is the only time period throughout the year when you are free to purchase, change, or terminate your individual health insurance plan, and is federally unified from November 1st, 2024 to January 15th, 2025 for the 2025 coverage year. By enrolling during this period, coverage will be effective January 1st, 2025 onwards. If enrolled after December 18th, 2024, coverage will have an effective date of February 1st, 2025. It is important to note that the December 18th deadline is extended by 3 days from previous years, but only for the 2025 coverage year. It is important to note that some states will extend the open enrollment period. For example, California, Washington, D.C., New Jersey, and New York have extended their open enrollment periods to January 31st. Rhode Island has extended its open enrollment period to February 28th due to special circumstances. And Idaho has an open enrollment period that runs from October 15th to December 16th. During the open enrollment period, enrollees can enroll through the federal health care exchanges, state health care exchanges, or directly with insurers. Enrollees with incomes up to 150% of the federal poverty level, i.e., $22,590 per year for a single person or $38,730 per year for a family of 3, can also apply for a premium subsidy and can enroll at any time throughout the year. If you miss the open enrollment period, You cannot purchase or change your individual health insurance plan unless you qualify for a special enrollment period. Special enrollment periods are triggered by qualifying life events. Federally mandated events include expiration of COBRA coverage, loss of employer-provided health insurance due to job loss, moving to a new health insurance coverage area, marriage or divorce, birth or adoption of a child, and loss of other health insurance coverage. Once these conditions are met, the enrollee will be granted a special enrollment period of 60 days from the date of the event or loss of insurance coverage. Beginning in 2025, coverage enrolled during the special enrollment period will be effective the first of the following month, even if enrolled mid-month, whether enrolled in the federal or state exchange. For example, for those whose COBRA coverage expires, the special enrollment period will count 60 days from the date the coverage expires, and enrolling during this period will make the new health care coverage effective immediately after the COBRA coverage expires. And for those moving to a new zip code area, they will have 60 days from the date of the move to purchase health care coverage options in the new area. It is important to note that supporting documentation, such as COBRA expiration notices, proof of move, proof of marriage, etc., must be submitted during the special enrollment period or this benefit will not be available. Additionally, employer-sponsored coverage is offered at a different time than individual coverage, usually in the fall of each year during the employer's open enrollment period, which coincides with the individual's open enrollment period. The enrollment period for new employees is within 30 days of starting employment, and if you miss it, you will have to wait until the following year. The next point to make is where people are most likely to step into the pitfalls, centered on network restrictions, provider network status, and costing rules. Most typically, the distinction between in-network and out-of-network and the pitfalls of a multi-tiered network system. Most health insurance programs, especially HMOs and LIPAs, cover only the costs of in-network providers, while out-of-network costs are either not reimbursed or are reimbursed at a very low rate and do not count against the annual out-of-pocket maximum. Even more insidious are multi-tiered networks. Some insurers subdivide in-network providers into preferred networks and non-preferred networks, which have different co-payments and co-insurance rates, with preferred networks typically having rates that are 10 to 20% lower. This division makes it difficult for enrollees to choose, and if they choose a non-preferred network, they will be responsible for higher costs. Another common pitfall is the issue of non-network providers in acute care. According to the Kaiser Family Foundation 2021 study, 50% of EMS transports are non-network services. As of 2025, this data has not been updated. Even if a participant has an HMO plan, this cost is still fully paid for on their own and does not count toward the out-of-pocket maximum. Even more problematic, even if the ambulance belongs to an in-network agency and takes the patient to an in-network hospital, the anesthesiologists and emergency physicians at the hospital may belong to contractors and are not in-network, and their costs are likewise not reimbursable. There is no way to verify this in advance of an emergency, and participants often don't realize they've stepped into a trap until they receive their bill. To avoid these traps, there are a few key measures to keep in mind. First, carefully check the list of in-network providers and the drug list in the insurance plan before enrollment to make sure that commonly used doctors and drugs are covered. Second, take the initiative to confirm the network status of the doctors and providers before seeking medical treatment, especially in emergencies, and try to ask the hospital to arrange for in-network doctors. Third, keep all the bills and carefully check the bills. And third, keep all the medical expenses. Bills, double-check the bills and insurance reimbursement details, and communicate with the insurance company as soon as problems are found. Fourth, make full use of the insurer's customer service. Before enrolling in the policy, ask for details such as the rules for calculating expenses and the criteria for determining eligible life events. These time windows and hidden traps essentially reflect the complexity of healthcare policies and insurers' cost control strategies. If enrollees lack understanding of these details, they can easily face the risk of missing coverage or high medical expenses, which is what the U.S. healthcare system has been criticized for. Today, we have put together a comprehensive explanation of the core rules. major programs, government programs, and key considerations for enrollment in U.S. health care, aiming to help you understand the logic of the system's operation and potential problems. The original intent of Medicare was for people to be covered in the event of illness without having to worry about costs. However, the private healthcare system in the United States has become increasingly complex and expensive due to bundles of benefits, leaving countless people in dire straits. Despite being supplemented by government programs, the problems of insufficient coverage and wide regional variations remain prominent. Understanding the healthcare systems of different countries not only allows us to see the advantages and disadvantages of different systems, but also allows us to cherish the current healthcare resources. Finally, I would like to emphasize that all the content shared today is based on the latest data from authoritative organizations such as the U.S. Department of Health and Human Services, CMS, IRS, and the Kaiser Family Foundation to ensure the accuracy of the information and is in no way fictitious or misleading. If you still have questions or would like to know a specific detail, feel free to leave a comment in the comments section to discuss. That's all for today's content. Please subscribe to our channel and like and share it with your friends around you who care about international healthcare topics. We will bring you an in-depth explanation of more important topics related to global healthcare next time.